Hello, welcome to JNO Live. I'm Seth Kruger, Digital Media Editor at JAMA Network Open. Of course, if you're following along live, send us your questions or comments on Twitter at JAMA Network Open or in the comment box under the video on Facebook or YouTube. Today, we are talking about risk factors associated with mortality among residents with COVID-19 in long-term care facilities, Ontario, Canada. And we've got first author, Dr. David Fisman with us. Welcome, Dr. Fisman.
Thanks for having me on.
Well, really glad you could join us. This is an interesting topic, and I think one of the points that's I think gotten a lot of discussion, particularly in the lay press in the U.S. and a lot of political discussion about the infections long-term care facilities. So first, if you could just tell us a bit about who you are, why you did the study here.
Sure. So I'm sort of a lapsed infectious disease physician. I trained in ID and then started doing some public health stuff about 20 years ago and sort of left the path and turned into an epidemiologist. So my day job now is that I'm an epidemiology professor at the University of Toronto at a place called the Dalla School of Public Health. And I do a little bit of clinical infectious diseases on the side as well. And like a lot of my colleagues at the School of Public Health, as COVID has taken off, whatever we were working on has sort of been put aside, and many of us have been pulled into working on the epidemiology of COVID. We're particularly lucky in Toronto because our school's dean, a guy named Staney Brown, is also part of the provincial government's response team. And Staney has pushed really hard, and this is very unusual for us in Canada, where we tend to be a nation of data huggers. Staney has pushed very hard for epidemiologists in Ontario to get access to really good data in real time so that we can help inform the province's response to COVID. And so what we've mostly been doing is kind of modeling disease dynamics of COVID in our community, which looks a lot like, in Illinois or other US states. I think we've all been through a very similar process. In March, we started to hear rumblings about outbreaks in long-term care facilities, and data became available, which are imperfect data for a variety of reasons, but they became available in late March on what was going on in long-term care. And so we did this actually as a pretty quick analysis to just try to sound the alarm about what was happening and what seemed to be unfolding. And of course, it circulated internally with folks in government and took a longer time to become a publication, a peer-reviewed publication in a journal. But I'm really glad we did it because I think it's an important, almost historical document about the moment in time when the long-term care crisis took off. And in Canada, most of our deaths, we have a twice the case fatality that you have in the US. We're up at about 8% versus 4%. And that really reflects the fact that our big failure in Ontario and Quebec and somewhat in Alberta was that we did not protect long-term care facilities adequately.
Yeah, and that's an interesting topic that I want to get back to. But do you want to hit some of the summary points from the data from your paper? So some of the big things, it looks like you had data from basically most of March and the beginning of April on deaths in long-term care facilities. Can you tell us a bit about what you found?
Sure. So there were two parallel data sets, which made this a little bit challenging. One was something that came from, its government. So there's actually separate ministries of long-term care and health, and each of them have their own record set, which don't always agree perfectly in terms of what's going on. So we were able to acquire death data in long-term care from the Ministry of Long-Term Care, and then we had our data on what was happening with cases in Ontario from something called IFAS, Integrated Public Health Information System, which did not at that time have a long-term care flag in it. So we didn't really know. We knew how many deaths there were in each data set. We didn't really know who was who. But what we were able to do is look at a time series of deaths and see how risk was changing over time per long-term care resident, and sort of subtract those deaths out from the master death data set and say, well, these are our comparator deaths. These are deaths among people who we don't think are in long-term care, and how do those deaths compare? And what you saw is sort of this alarming divergence where I think we say in the abstract, by April the 11th, the relative risk of death from COVID, if you're in long-term care versus outside long-term care, is something like 90-fold. And unfortunately, that's actually been borne out and been validated. And in Ontario, we're up above 2,000 deaths in long-term care. Now, it almost looks quaint at this point to look at this paper and say, here are these people pulling the fire alarm and saying, my God, we have 80 deaths in a relatively small population. That's a huge death rate. And in fact, it was only getting started. And now we're well over 2,000. And we've had mercifully few deaths. We're a population of about 15 million. We're under 1,000 deaths outside long-term care homes in Ontario. So really our big failure was we didn't protect long-term care. So I think that's the important thing is, it's just sort of some time series stuff where you can see the trends in those two groups diverging from each other and how fast this is taking off. And of course, that model was validated. And then the other thing we did was we looked within long-term care homes at what the predictors of death were. And I think this is probably the more important finding in the paper is you can predict resident deaths based on infections in staff, but you can't predict them based on infections in other residents, which is somewhat suggestive of a directionality of transmission, which kind of makes sense because it's staff people who are the mobile ones who are going in and out of the facilities. And in our system, we also have a lot of folks moonlighting at multiple, not moonlighting, but doing part-time at multiple facilities. And we think that created a network which enhanced vulnerability and enhanced the rate of spread between facilities. So, that obviously opens the door to how you prevent this in future. You decouple the network of long-term care facilities by restricting workers to a single facility, paying them a decent wage, paying them some danger pay, give them some personal protective items, and keep them at the same facility so people don't move this all around the long-term care system.
Yeah, that's an interesting point because I think that's something that at least makes sense to me based on some of the other data we've seen on healthcare worker infections is that the bigger risk that healthcare workers seem to have was early on before we recognized the importance of PPE and kind of universal precautions, universal masking at work by both patients and healthcare workers. And that, even kind of paradoxically, some of the higher risk people were people in the non-COVID areas. I don't want to single anybody out, but, it was like the ER docs and ICU docs were, at higher risk, but not the highest risk. And it was like the elective surgery floors that were the highest risk because it wasn't as obvious to do the kind of protective procedures.
Yeah. It's a very sneaky little virus. It's almost engineered to tie us up in knots and make us crazy.
Right. So before we get into a little of the context, I'd love for you to provide just some of the top line numbers that you found. It was out of about 630 long-term care facilities, there were about 270, so about 40% that had reported cases at the time. And as you described, compared to the population, there were about, just talking about people 70 and older, about 230 deaths out of 1.7 million people in Ontario versus 83 out of 79,000 long-term care residents who died. And you can tell that's just a pretty big difference in fraction there. So the risk is definitely higher, and you get an IRR of about 13 when you're comparing the age match group, and as you said, about 90 against the general population. Does that sound about right?
Yeah, that is right, and this wobbles somewhat depending on who you choose to use as the comparator group in terms of community living older people. So we did this a few different ways and sliced and diced it, just compared to 80-year-olds, compared to 70 and over, compared to 60 and over, because we didn't know what the appropriate comparator group would be. And of course, the wider the age range you use, the younger the folks you include in the lower bound of the age range, the bigger the divergence looks. But still, as I recall, I'm just going to flip through the paper here. As I recall, even if we compared them to community living 80-year-olds, I think the relative risk is still 8. I mean, it's a tremendous divergence in risk and accelerated over time. And that's the figure 1 in our model is just showing that acceleration, which we did as what's called an interaction term in the regression model. It's nursing home residents times time and times a linear function. So in a Poisson model, which is log linear, you see this tremendous sort of exponential takeoff in risk over time. Yep. Yeah. And I mean, just to editorialize in terms of where that curve is going, where it landed, because at this time it's 0.2% of nursing home residents dying from COVID. By the time this was all over, it's about 2.5%. So this is going to increase about 15-fold, I guess, over the course of the outbreak.
Sure. A couple of viewers on welcome: Roseanne Kenny, Zoran Juza, and Dr. Angel Desai has joined us. Welcome. Good to see you, Angel. And that's actually so a question I have for you for context. One of the challenges we've had is kind of how heterogeneous the outbreaks are in different localities. Where do you think you were, or where was Ontario kind of as far as the meat of the curve in the first wave with the data you had? It was, that was kind of, I'd say probably most, but not all of where we were in Chicago. How much of it was it for you?
Yeah, in terms of Ontario, we've actually been relatively quiet here since May. There's sort of a push to reopen the economy, and what you see is because Toronto actually has some settings which have been quite difficult to settle. We have some, for example, some community housing where this has really been hard to root out, and you have folks who work in essential businesses who come home to multi-generational households in crowded apartments. And that's been a real driver of persistent COVID in Toronto. We seem to actually have that under control at this point. But because of that, Toronto's economy opened slower than outside Toronto. And so what's interesting is over the last week or so, we now see outside Toronto's having more cases than inside Toronto, which I think just reflects the fact that their economies have been open for longer. It's been a bit of a controversial thing locally. Most health units in Ontario now have mandatory indoor masking, but the bars have opened. And whether or not that's a good idea, I I have my ideas about it. Others have their ideas about it. But that things like that may be associated with the surges we're starting to see. In terms of our first wave, something I'm very proud of, our obvious comparator, because we share a lot of border with it, is New York State.
Mhm.
And I don't think anyone really wanted to pull the trigger on locking down. But our premier, who's our version of a governor, did actually lock the province down about 2 weeks before New York State did. And as I say, we've had 3,000 deaths in Ontario. New York's had 30,000 deaths. They're pretty similar sized jurisdictions. New York's 19 million, we're 15 million. And I think, that to me, is it causal? Well, sure,
Right.
it's an observation, but that's consistent with models which would say that that 2 week lead time in locking things down when things are getting bad is going to save tens of thousands of lives. And that's something that, there's a lot of stuff, the nursing home stuff was done wrong here, but the lockdown was done right. And I think it saved thousands of lives. Yeah.
Yeah. It's hard, unfortunately, the I don't know, politics and disagreements resonate a lot with the experience we've had here and continue to have. And even places like New York, where the difference between New York City and the rest of the state, it can be so divergent. I'm curious, and you've kind of hinted at this a bit. The obviously not everybody in the population and not every group within the population is going to be at the same level of risk. And do you think the long-term care facilities were hit first because there's something special about people in long-term care facilities, or just the most vulnerable, or kind of the first population to catch fire?
Well, yeah, I think you see it. I think I was sort of at that time sort of likening COVID to, like a movie scene from Jaws where, there's the ominous music in the background, but you look out at the bay and nothing's happening. And all of a sudden the paddle boats start disappearing. The paddle boats that are going to disappear are the long-term care residents, because they're going to tell you there's something going on, because case fatality is so extraordinary, once you pass age 70. We're actually looking at infection fatality now in Canada. We've got our first toe in the water with seroprevalence data. We're a bit late to that. And even there, even infection fatality ratio looks like it's about 4% in the over 70s. So this is a very deadly disease once you get past age 70. And of course, long-term care, you've got folks with a bunch of comorbidities. You've got folks who can't really often tell you that they're feeling sickly. And then I think something that we're dealing with in Canada now as well is, I think there's a double-edged sword, and the collection of race ethnicity based data can be used for good or can be used for ill. We have not historically collected that in Canada, and it's been flagged as a problem for us, because clearly we have more risk in communities of color in metro areas in Canada, Toronto and Montreal in particular. And we have greater representation of new Canadians, immigrant Canadians, folks from multi-generational households, and people of color working in facilities like long-term care as personal support workers. So we've sort of had this terrible witch's brew of risk, where the folks who have lived in circumstances that's made it very hard for them to isolate, very hard for them to work remotely, indeed they're essential workers, have also been working in workplaces where they're pretty disempowered. As a PSW, you don't have a lot of clout in terms of how things work, and we've heard that from patients and families. If I don't go to work sick, I'm losing my job. So that fed a kind of vicious circle of vulnerability and disease and reimportation of disease back to people's households where it spread. So COVID, as in the US, and I think just because of the nature of data collection in the US, it's easier for you to look at this and say, holy crap, there's huge disparities along lines of race, ethnicity in terms of vulnerability. We have that in Canada. We just don't collect the data that allows us to clearly articulate that. So we're reduced to sort of looking at this ecologically and saying, oh, wow, the hotspots for COVID in Toronto are where, you have a higher fraction of people of color living, where you have a higher fraction of new Canadians, higher fraction of multi-generational households. So we're really, in that instance, we're hampered by the lack of race ethnicity data. It's very heterogeneous in our society too.
Well, I think the way you described how the unfortunate vulnerabilities that a lot of populations have was very eloquent, and I appreciate your insight there. That brings us to about the end of our time. Really appreciate talking with you. This is really important data, really really interesting discussion. So thank you for joining us, and thanks for the good work here.
Oh yeah, it's a pleasure. Thank you JNO for publishing our paper.
Absolutely. And of course, for everybody who's watching, you can get this paper and more at jamanetworkopen.com, where it's free and open access. We've got new papers coming out. Everything is free to download at 10 a.m. every weekday. And of course, join us next week, Tuesday at 3 p.m. once again for JNO Live. Take care and stay safe.
Be well. Bye, guys.